Welcome back to Diabetic Foot Files, where we expose what wounds are really telling us and why foot care and limb salvage should never be a luxury. Today's episode is a powerful yet necessary one and long overdue. Today we have and joined by Dr. Tom Hardiman, who is a dedicated podiatrist with more than 35 years experience in private practice. He is the medical director of medical monofilament manufacturing for more than 27 years. He is also on the Health Equity and Advocacy Committee for the American Limb Preservation Society. And he is someone who understands that limb salvage isn't just about surgical skills, but also about access, systems, policy, and justice. And in many communities, especially the underserved and minority populations, preventable amputations are happening at an alarming rate. Not because we lack the knowledge, but because we lack the access, resources, and structural support. And Dr. Hardman has been vocal about addressing these disparities, challenging the status quo and pushing for the system where quality limb salvage should be available to everyone and not just those who can afford it or live near it. So, welcome, Dr. Hardiman.
Thank you, Dr. Hutchinson. Pleasure to be here.
Thank you. Okay, quick. Dr. Hardman, what first opened your eyes to the healthcare inequity in podiatry?
Thank you for that excellent question. But before we go into that, I'd just like to take a brief moment to acknowledge the loss of Reverend Jesse Jackson in the United States. Today, his death was announced, and he was a real champion for equity and peace amongst all people. He was a huge civil rights leader around the time just with Martin Luther King back in the 60s, and he rose to great prominence and used his position to really help bring awareness to things like institutionalized systemic racism in all aspects of life here in the United States. So I would just like to acknowledge his sacrifice and hard work and advocacy for people all over the world, not just the United States. So what opened my eyes to this problem we call inequity in healthcare? And I it's interesting you asked me that question because my wife asked me the same question the other day. She said, "Why are you so passionate about this subject?" And she said, "In all the years that you were in private practice, I don't recall you being, so vocal and passionate about this." And she was absolutely right. And I feel bad about that. I think when you're in practice and I'm sure a lot of doctors, yourself included, can relate to this. You're so busy with your day to day and your schedule and your surgeries and your committees, and you're just in the grind 24/7 kind of, and you're just trying to keep up, and you're trying to keep up with everything in your practice and in your hospital and keeping up with the literature. And you're so busy, with that, you kind of have kind of a nearsightedness to the problem in front of you. So what happened in my case was, as I started to dial down and focus on just the things that I'm interested in medicine and surgery, I started kind of just focusing on diabetic foot problems and wound care. And once I stopped doing everything else and just focused on that, I think I started getting a little bit more time to explore, what the nature of these problems are. And as you start to back away and get a bigger picture, like all of us, in medicine, we're lifelong learners. So, we're extremely curious people, and we start asking questions like, why? And so in my case, I started saying, okay, why are we getting, why are these people with diabetes getting these foot problems? And peripheral arterial disease is common, minor trauma, challenges with wound healing, and so forth and so on. Social determinants of health are a problem. But I guess in my case, I feel like I went from, looking at the problem and then saying, well, why are some people getting them and not others? And this led me to start doing some search in the literature, and this was back in late 90s, early 2000s, and I started seeing articles that were talking about disparities. And I was like, well, what are disparities? What is that? What are those? I just don't know what they are. And I think it's important at this point to just talk about language and terms and definitions, because we need to make sure we're using the same language and we're talking about the same thing. So to me, and these aren't my definitions, when we have a wonderful thing with AI now, and you just, can find out anything. And so you can just discover the common language. So disparity is a measurable difference in outcomes, right? And it's like, oh, okay, well, that's the data, that's the result. And so I'm looking at the disparity that, well, people of color are having these problems 3 to 4 times often than anyone else. And so, why is that? And then I back into something called inequity. Well, what's that? Well, inequity is an unfair or unjust distribution of resources, right? Or lack of access. And so I say to myself, well, why is that? Because I'm curious, right? And so then you come to inequality, and it's like, that's an uneven distribution of something. So the haves and have nots. Why do some people have access and some people don't?
Mhm.
And then you say, why? And then you come to this very, very, you know, strong word called racism.
Mhm.
And it's like, well, I'm a podiatrist. I'm a foot specialist. I want to take care of people, who have foot problems, who have diabetes. What am I doing, looking up, these terms, racism? What's that? I think I know what it is, but what does everyone else think it is? It's a system of power or prejudice. It could be an individual. It could be a complete system of power, like a hospital or, any kind of financial institution. But that's the root cause of all of these things. And then I come to start looking at, racism in the United States.
Mhm.
And when did that start? And we have a horrible history here of something called slavery, which didn't end until the late 1800s. But our economy and our country was, a lot of it was built on the backs of people who were enslaved. And this created a system of racism where some lives were valued more than others. And it's a horrible, ugly history, but the legacy of that system still exists in the United States in 2026. And
Yeah.
and some of that is just, built into the system of systems we have that we call healthcare.
Mhm.
So it's a long-winded answer to your question, but that was my journey. I just started looking
Yeah.
at the problem and trying to find the root cause of the problem. So the fact that we have over 175,000 amputations annually just in the United States alone, one every 3 minutes, 3 to 4 times more often in people of color, can be traced back to institutionalized systemic racism and lack of access to proper care in a timely manner, the social determinants of health that surround all of this. And it's a big, big problem and not something that we can easily fix, certainly as an individual, but hopefully, together over time, we can find a solution for this problem. And, Jesse Jackson had a quote that, no matter if you're yellow, green, purple, red, or white, we're all God's children in his sight. And we have to start looking at each other as everyone is equal and deserves equal treatment. And everyone deserves equity in their health care. And health care should be a human right, not a commodity, not a privilege that some can afford and some can't. So we need to be honest about what the problem is. We need to talk about some of the ugly history that led us here, and we need to start digging deep for solutions. And we need to put people ahead of profits when it comes to healthcare. And we have to put the mission before money. And until we get to that point, we're going to continue to have these problems. You and I both know, Dr. Hutchinson, that we've been talking for over 40 years, 50 years, that 80% of all diabetic foot complications are preventable. Yet
Yes.
here we are in 2026, and we're still seeing an outrageous number of preventable amputations happen all over the world. Every 20 seconds, somebody loses a limb due to diabetes.
Yes.
And, where's the outrage about that? 70% of these people will be dead within 5 years after this loss of limb. It's worse than all cancers except for lung and pancreatic cancer. So we need more awareness on this problem. And hopefully, you and other people with this podcast and other types of attempts to increase awareness are going to be part of the solution.
Yes, thank you. But honestly, Dr. Hartman, I did not think about how deep it was when it comes to the disparity. I was trying to figure out where you were going with it, and you made me understand that it's literally it did trickle down into the healthcare system. The
Right.
background, I was very kind of like a little epiphany just now with that, and why I never even thought about that. But that makes
Well,
so much sense.
let me ask you this. Did anyone ever discuss this when you were in your medical education or training?
Well, okay, so the only reason I started thinking about that, I had a patient once, and it was when I was doing a preceptorship, and they were doing clinical trials, and there was a patient, it was a lady of color, and her husband always came with her during the wound dressing. And he always carried this new old newspaper with him that pretty much was an article about the healthcare disparities and how Black people were more likely to get amputated than other
Wow.
races, right? And
Okay.
he carried this newspaper and he made me read it. I just said like right after, preceptorship. And I was like, wow, I
That's
didn't know
wonderful.
that. Yeah, I
That's
didn't know that, but
wonderful. Yeah.
it was an old paper. It was an old
Yeah.
newspaper.
Well,
Yeah.
that's a wonderful story, and it's a great example of how we learn from our patients as much as they learn from us.
Yes, definitely. But
Yeah.
I like that. I think her husband was advocating for her. Like, because people are so quick to just listen to what the person says and say, "Oh, yeah, I this needs to be amputated right away," yet not knowing that there are other routes.
Yes.
And that's one thing I've noticed
Yes.
for a lot of patients.
Well, diabetes is not an individual challenge, right? It's a family problem, right?
Mhm.
It takes a village. It's not just, when you have a person with diabetes in your family, the whole family kind of supports that person in an, in most instances,
Mhm.
hopefully. And so, I think that's a good example of that, what you just mentioned. So I think this is a great segue to your next question.
I mean, with the patient story, okay,
Yeah.
was
I had
there
a patient you asked the
was
question.
okay. Was there a patient story that changed how you saw the system?
Yes, yes. So when I was a resident, I was doing a rotation at the San Francisco General Hospital, and I was given the dreaded task of it was the first time I was ever asked to do this, to go into a patient's room to have him sign a consent for below knee amputation for the following morning. So I really did not want to do it, but I was uncomfortable with it, and my chief resident said, it's part of the job. You have to do it. So I went into this patient's room. He was an African American male in his early 50s, a blue collar worker, construction worker, and he was such a nice person. I got to know him a little bit in the few days prior, and we were trying to assess him for limb salvage, but the decision was made, certainly not mine, but at some level that was not possible. And so I went into his room, and his entire family was present. His wife, his 3 children,
Mhm.
and I think a couple grandchildren. The room was crowded, and I said, "Oh, gee, Mr. Smith, I don't know his name. I of course forgot, but just use that for example." I said, "I'll come back another time. I need you to sign some paperwork for tomorrow." And he's like, "No, no, no, doc, come on in. I know you guys are busy. Let me, sign the paper." And I said, "Well, I have to go over it, with you to make sure you understand." And so I was nervous. I felt uncomfortable. I went over, all of the, risks and so forth. And he signed the documents, and he reached out to me and he said, "I can tell this is bothering you a lot and you're upset." And I said, "Well, I'm a little nervous. I've never done this, part of the job before getting the consent for this." And he said, "Look, doc, don't feel bad. You guys did everything you could. I appreciate you all and understand what needs to be done. You did everything you could for me." And, did everything you could to save my leg. And so I thanked him. I walked out into the hall. Sorry, the story kind of stuck with me, obviously, but I felt terrible and I started crying. And because in my heart, I didn't feel like we had done everything. I
Mhm.
felt like we had failed him, not necessarily our team, my fellow residents and attending, but the system. The system failed him.
Mhm.
And at that point, I felt like there's no way in hell I ever want to be. There's no way I want to ever do this again. This is not the kind of medicine I want to do. This is not what I got into podiatry for. I'm going to be a sports medicine guy, and I'm going to take care of healthy people, and I'm going to help them run marathons and triathlons, and we're going to talk about biomechanics, and I'm not going to get myself in a situation like this again. So that was my patient's story. But as it turns out, we plan and God laughs. So I ended up not getting my sports medicine residency and fellowship that I really wanted in San Francisco. As a matter of fact, I was very desperate to find any residency position beyond what I had at that point. I must have, well, I misspoke. I said I was doing my residency. I think I was just doing a rotation as a fourth year student in that story. So I hadn't been a resident yet. I was still a student. So once I graduated, I was desperate to find a residency, and I found out that the VA hospital in San Francisco, where I was living, had just added a couple more spots in their program. So I quickly put in an application. I got an interview. I got one of the slots. Thank goodness. And come to find out that it was a diabetic foot type program and a limb salvage program. And I apologized to my mentor, Dr. Richard Stess and Peter Graff. I said, "Sorry, guys, I think you got the wrong person here because I'm going to be a sports medicine guy." And they just laughed and they said, "Well, we'll see about that. We'll see about that." And a month later, they came to me a month later and said, how are things going? How do you like it?" I said, "I'm hooked. You got me for life. This is what I want to do. This is so rewarding. It's so satisfying. It's so challenging. There's so much to learn." And that was, how I got on, the road towards being a diabetic foot guy.
I love that. And I hope other podiatry students can hear about this. So thank you, Dr. Hardman. So, what are the differences do you see between a well resourced patient or underserved patients with the same mood?
Well, the big difference, I think, really is it comes down to two words: unequal access. So, you know, the haves have the access, and people that, you know, have much less access. So that's, kind of the inequities we're talking about, right? I mean, that's the part that really is unfair and unjust. And, is so disturbing when you confront it, when you see it. And I'll be quite honest with you, where I practiced in Plymouth, Massachusetts, it was a very upscale community. I didn't confront a lot of inequities in that community. I grew up in another place called Brockton, Massachusetts, where there is a lot of inequities, and I would go there occasionally and volunteer and speak and so forth. But I could see, the tale of two different places, right? And a tale
Mhm.
of two cities, so to speak. And I did volunteer in some homeless shelters and so forth along the way as well. And I did do some mission trips. One in particular stands out to me there. My wife and I, who's a nurse, we went to Trinidad. And, when you go into, developing countries and Caribbean islands and things, you see things that you just can't forget. And
Mhm.
it's just appalling what we take for granted sometimes
Mhm.
here in the United States compared to what people are dealing with in other places around the world. And sometimes not even too far from our own homes. It could be, 20 miles away. And it's a completely different scene than what you're experiencing in your, own backyard.
That's very true. So, Dr. Hartman, why do you think underserved patients often present so late when it comes to that?
You know, a lot of it goes down, I think, comes to the social determinants of health, right? If you're challenged with transportation,
Mhm.
if you're challenged with money, if you're challenged with n- not having care community or family around you, it's hard to get the care that you want. And
Mhm.
some of it also is culture. And what I mean by that is in some cultures, going to the hospital or going to someone when you have a hole in your foot, so to speak, a diabetic foot ulceration,
Mhm.
it's extremely frightening experience because culturally you may have the perception that, well, every time anyone I've known who's gone to a hospital or a clinic with a hole in their foot has come back with one leg,
Yes.
right?
Mhm.
So it's like that's a problem. It's an education problem, and that creates bias. And it's an understandable thing. They're afraid of doctors
Yes.
sometimes, and
Mhm.
I'm sure you've seen that as well. So that's how I think I would answer that question.
Mhm. So that kind of comes into the role when it comes to, let's talk a little bit about transportation, job inflexibility, and caregiving roles that delay wound care. Because I've had quite a few patients. One time, can I just say this? One time I had a
Yeah.
patient who came in, and this is like last year, 2 years ago when I was practicing in Jersey, and she came in and she definitely had gas of that toe. And she literally I told her, "You have to go to the ER now," like, and she literally told me she had to go back to work and finish the end of the day or she'll lose her job. And I was just like, "I will call let me speak to your boss, let me write you a note." And she was, like, calling her boss, trying to tell him, like, "The doctor says I have to go to the ER." And I was like, "Yeah, she has to. This is like, she could lose her toe." So,
Yeah.
yeah.
No, I think that's a great point you just made. So, I mean, all of those things, like when we're doing our history and physical, uh, this is something that dawned on me too late in my career. But I had and the reason it clicked finally was I had a patient, a middle aged man. I did a matrixectomy on him, so I removed a portion of his toenail permanently, right? Because he had a reoccurring infection. And this is a procedure we do all the time, right? We don't think too much about it, and in terms of the technical difficulty, whatever. And he seemed like a pretty well put together guy. Well, it turns out, well, his toe got so incredibly infected, and it had such a vast array of rare organisms. I had never had a complication like that before. And I finally said to him, I don't understand this. I gave you the wound care instructions and I told you what to do as far as dressing changes and so forth. And he said, well, to be honest with you, I haven't been doing that. And I said, well, what's the problem? He said, well, I live in my car and I don't have access to, anything like, to soak my toe in. and I've been soaking it in the toilet occasionally
Oh,
because that's the best I could do. And so it turns out that this gentleman that I operated on was homeless. He was recovering a drug addict, and he had mental health issues. And he ended up almost losing his toe. He ended up in a long term care facility for IV antibiotics for 6 weeks. And I felt terrible about it. I used to go visit him and bring him, magazines or, different things. And I bumped into his, family once, and I just apologized profusely, that I had no idea that he was facing these other challenges. But I think my point in telling you the story is we don't take the time sometimes when we do our history to do that deep dive into the social determinants of health to make sure that this person is equipped to do their part of the job and
mhm,
to do it as well as they need to do it in order to get, as good a recovery as possible. So I think knowing your patient is so important. Knowing them, enough to know that they have what it takes to work with you as a partner in their recovery, whether it's a diabetic foot ulcer or reconstructive foot surgery or a minor procedure like that.
I definitely agree with that. So, do you think there is conscious bias that affects how aggressively some patients are treated when it comes to limb salvage?
Yes, I do. When you look at the fact that 65% of the people that end up with a lower limb amputation never have any vascular studies preoperatively, that tells you something. And most of those people are people of color. So if you look at, in the United States, the Medicare and Medicaid population, and then you compare those patients that have limb threatening ulcerations to private insurance population. The population that has private insurance more likely is going to have more vascular assessment done, and they're more likely to be referred for vascular reconstruction. So again, we're back to, what are we talking about? We're talking about, things like inequality, inequity, disparities, racism. So there's no whether, and I don't think it's, again, a lot of times this isn't on the surgeon, it's not on the doctor, but it's the doctor is working within the confines and parameters of the system that they happen to be in. And they can't get approval perhaps for, they can't get, prior authorization for this study or that study, and their hands are tied. And and as time goes by and this limb threatening problem becomes worse and worse over days and weeks, they have no choice sometimes but to amputate. And it's I don't know, I've never met a surgeon who would say this is one of their favorite procedures. Nobody feels good about this. No one,
Mhm.
because everyone acknowledges it as a failure of the system or care, or something failed along the way. And I when I talk about, things like racism and inequity and equal, I'm not targeting individual doctors, because I want to make
Mhm.
that clear, because we all got into this business for the same reason. We love people, we want to help people, we want to make people better in terms of, their health and wellness. And but what we end up is finding out we work within certain, confined structures that we had no idea what the rules of the game were when we were in medical school and doing our residencies and things. And then you get out and you find out a lot of it's driven by money and
Mhm.
profit, and the bottom line is always being protected. So, this is where, we run into these. It's like there's a word for it, cognitive dissonance. And I think this is what actually leads to a lot of burnout amongst physicians, because we all are a bit idealistic in our
Mhm.
thinking, and we want to save the world. And then we have to encounter the world and find out the realities of the world, and they
Yeah.
and the value system of the world doesn't necessarily align with the value system we have as healers, and we struggle with that.
Yes, I totally agree with you when it comes to that, unfortunately. So, what's something I might be bouncing around with the questions, but because you mentioned about the housing instability and you not knowing that that patient was homeless, which is
Mhm.
incredible that they were putting their toe in the toilet sometimes.
Right.
But how
Mhm.
does food insecurity, in your opinion, affect wound healing, like malnutrition?
Well, garbage in, garbage out, right? So, um, when you think about it, I mentioned going to Trinidad. When we were in Trinidad, I would see young people standing on the corner with crutches with an amputated leg. And these were people, they appeared to be in their late 20s, early 30s. And I said to my driver, I said, are there a lot of sharks around here? And he said, what are you talking about? I said, all these young people, they're missing parts of their leg. Are they victims of a shark attack? And he laughed. He said, Doc, it's sugar, man. It's sugar.
Oh,
And I
wow.
and I was like, what? What? He goes, diabetes, diabetes. It's the sugar. And I was like, and I couldn't believe such young people were being impacted this. And then we drove up into the mountains, and what did we see? Up in the rural, the mountain communities, villages, they call them sugar shacks. And they're small buildings, and all they sell is soda and white bread and candy and
My
processed
gosh.
food. And this is what they sustain themselves on, what little they can grow at home. They may have a couple of chickens or have a little garden, but a
Mhm.
lot of their nutrition comes from these empty, calories. And so I think nutrition, as we've come to appreciate, plays such a huge role. I don't think I had more than 2 hours of nutritional education in my medical training. I don't think there was an emphasis put on it back in the day. Hopefully it's changed. I think we've come to realize you need proteins and you need vitamins to heal a wound. Just like gardening, you need to have the right type of nutrients in the soil. Same is true for trying to heal tissue. So it's a huge, huge issue. And again, something I think that in the wound care specialties is being appreciated much more.
Yes. So, Dr. Hardiman, what frustrates you the most about the system when it comes to trying to save the leg or limb?
What frustrates me the most? I think just the lack of awareness amongst the general population. I think when we, I will give you an example. I had a new patient come to me who had been diagnosed with diabetes 10 years prior. I walked into the room to see her, and she was, in her mid to late 30s, and she's crying. And I apologized. I thought immediately she had been waiting too long, or maybe my receptionist was rude to her. I hope not. But I said, I'm sorry. I don't know why you're crying. If it's any of these things, I apologize. She goes, no, 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 doc, it's not that. I just know what you're going to tell me. And I was like, well, I've never seen you before. I don't know what I'm going to tell you either because I've never talked to you before. She goes, no, I know what you're going to tell me. And I'm like, well, what is that thing that you think I'm going to tell you? And she goes, I'm going to lose at least my foot or leg eventually. And I said, why would you say that? And she said, because it happened to my father, it happened to my grandfather, it's happened to my uncle, and I know it's going to happen to me.
Mm,
And I said, well, okay, let's talk about that fear. I said, fear is false evidence appearing real. That's what, it stands for, FEAR. I said, do you smoke? She said, no, I don't smoke. I said, did they smoke? Yeah, they all smoke. I said, oh, and do they, did they exercise? No. Do you exercise? Yes. Oh, okay. I said, do you see an endocrinologist as well as, yeah. Oh, good. Do you keep your A1C within, the parameters that you should? Yes. Okay. Do you check your sugar daily? She did everything right. Everything right. I said, so you're a well managed person. You're a person who's managing their diabetes. If diabetes isn't managing you, you're running the show. It's not the other way around. So the chances of you losing your limb are infinitesimally small. There's a 99.9% 9%, you'll never lose your limb, in my opinion. And if you look at the literature, that's pretty much, what evidence shows. So I said, you don't fit the definition of someone who's at high risk. You have adequate sensation, you have good blood supply, you have no structural deformities, you have no lesions on your skin. So I guess to answer your question is the lack of awareness, and there's this perpetual fear. Amputation is a word almost it's almost feared more, in my opinion, than the word cancer.
Mhm.
you know People talk about breast cancer and colon cancer and other types of cancers, skin cancers, kind of it just flows up there. But if you mention the word amputation, nobody wants to talk about that word. Nobody wants to talk about it because it's the fear that surrounds it. And I guess my frustration is that too many people think it's an absolute
Mhm.
unavoidable complication, and it's so avoidable, and we know 4 out of 5 times we can prevent it, even with a person with moderate to high risk.
That's good. That's good to know. So, what policies do you feel need to change to help reduce amputations?
I'm sorry, what was that last
I
question?
apologize. What policies do you believe need to change to reduce amputations?
Well, I think that the biggest policy that has to change is the in our country, and I'm speaking from a U.S. perspective,
Mhm.
it's the way our insurance company is set up. And again, we don't have a healthcare system. We have a sick care system, and we have a system that rewards activity, such as a busy ER, a busy OR, busy labs, busy imaging. When patients win, hospitals lose in our system because it's money before mission, and that's what's going to have to change. And it has to change because it's unsustainable financially. We spend over $5 trillion a year in the United States. It's 20% of our gross domestic product, almost one out of every $5. And Medicare and Medicaid budgets can't afford to sustain that level of cost anymore. And private insurance is becoming so expensive, even with high deductibles and premiums, that's getting out of reach. So the way we finance healthcare or sick care here, we have to get away from a sick care system and have a true healthcare system. And we need, Desmond Tutu has a great quote that we have to stop standing around wondering why people are falling in, to the river, and start going upstream and preventing it and finding out why they're falling in. And that's what we need to do, go further upstream on all these problems, particularly chronic disease, because chronic disease is really what's costing our country the most money. Metabolic diseases and like diabetes, hypertension, cardiovascular disease. And if you throw in asthma and mental health, those are the biggies that we really have to focus on.
Yes. So, what rights do patients have that they don't realize that they actually have? The right to say no.
Well, patients have a voice, and I think
Mhm.
they need to use it. And if they're not willing to use it, just like the story you told me at the beginning of the interview, they need a family member that's going to advocate for them. Like that great story you told me about the husband who was carrying around that old article, about disparities in terms of diabetic foot care, and they need to question, and they need to say, "Hey, doc, what is my vascular status?" We need to do a better job educating people about the questions to ask. Hey, doc, have you done a monofilament exam on me? Do I have,
Mhm.
severe, you know, neuropathy? Do I have protective sensation? Hey, doc, what do you think about my footwear? Is it appropriate for me? Does it fit? Does it fit the way it's supposed to fit? You know, I think patients need to understand they're at the center of their care. But
Mhm.
but I think they wait for us to give them permission, right? So
Mhm.
people don't care how much you know, until they know how much you care. And I think
Oh,
when you establish that relationship with a
yes.
patient and you can build trust and they feel safe asking you questions. But let's face it, most patients are intimidated by a doctor who
Mhm.
comes in and it's like like they think that they're somehow below us, and we have to put them at ease and say, no, we're one on one, we're straight, you and we're on the same level. I'm taking care of you and you're helping me do that, and we're partnership in your care, we're partners in your care, and we're going to work together.
Yes.
So I think that's, patients have to, but we have to set the tone. We have to make them feel they deserve that role and that we respect them in that role.
That's true. Very true, Dr. Hardman. Okay, so these we only have a few more minutes left, and I wanna do a part 2 with you, so but okay, so if you had the ear of every healthcare decision maker for 30 seconds, what would you say?
I'd say that in the United States, like I said, we lose over 175,000 limbs per year. This is, again, 3 to 4 times more often people of color. And 70% of those people are dead in 5 years, worse than most cancers except the lung and pancreas. And I know I said this already, but I'd say it again if I had the ear of these people. And 80% of the time we can prevent this. So, let's just all do our jobs and let's give people the treatment and care we would give our own family and friends.
Yes, Dr. Hardman. So thank you, Dr. Harmon. That was a powerful conversation. I definitely do believe I'm going to do a part 2 with you in the near
Okay.
future because you're
Okay.
amazing to speak to. And you're also a very, very great mentor. I'm so grateful for you.
My
And
pleasure.
health equity in limb salvage isn't just a talking point, it's a responsibility.